In today's video, I will discuss about approach to hemolytic anemias. Mainly, I have collected the information from chapter 105 of Harrison as well as from the CMDT textbook. So, we will see how to approach a case of hemolytic anemia. First thing is, we need to establish or we need to suspect hemolytic anemia. This is the most important thing. So, what should be the factors which will be giving clue towards hemolytic anemia? First thing is, there should be evident anemia in the form of decreased hemoglobin below the normal range, and there might be evidence of jaundice, that is increased bilirubin. Mainly we will see indirect hyperbilirubinemia, and often when we consider mainly extravascular hemolysis, usually we will see splenomegaly. So we can consider these three as the triad of hemolytic anemia. Triad. Along with these three, there are some other clues which will hint towards hemolytic anemia. For example, if you send for peripheral smear, there might be proof of hemolysis in the form of cystocytes, spherocytes, sometimes sickle cells, target cells, and if you go theoretically, there might be hinge bodies. So all these things are the evidence which will hint towards hemolytic anemia through peripheral smear. So whenever you are sending for peripheral smear, mention it that suspected hemolytic anemia. Then it will be easier for the pathologists to concentrate in relation to such abnormal morphology of the RBCs. Similarly, when it comes to retic count, usually there will be compensatory increase in the reticulocyte count in case of hemolytic anemias. So this is the general picture. If we see such things, we have to suspect hemolytic anemia. Now, once you are thinking it is possibly hemolytic anemia, immediately you just divide it into two things, whether it is intravascular or the hemolysis is happening extravascular. So in intravascular, mainly inside the blood vessels, lysis will be happening, whereas in extravascular, mainly in the reticuloendothelial system and most commonly in the spleen, this action will be happening. So this should be the first division. So here usually we will get splenomegaly if it is extravascular, whereas in intravascular there might not be splenomegaly often. No splenomegaly in intravascular cases. So whenever you get any case of anemia, don't miss to palpate for the spleen to look for splenomegaly, because it is one of the clue towards hemolytic anemia, in particular extravascular hemolysis. Other than spleen, what will be the other factors which will help us in deciding intra versus extravascular hemolysis? For example, you might be knowing about LDH levels. So it will be elevated in both the situations, but very high, almost up to 10 times, 10x increase we will see in intravascular hemolysis, whereas it will be normal or slightly elevated in extravascular hemolysis. Coming to haptoglobin, haptoglobin has the function to bind to the free hemoglobin which might be released after hemolysis in the vasculature, because the free hemoglobin is always toxic to the body. So the haptoglobin will make sure that such free hemoglobins will be captured by it. So definitely, because of utilization of haptoglobin in case of intravascular hemolysis, there will be decreased levels, whereas in extravascular hemolysis, which is happening in the spleen but not in the vasculature, there we will see normal levels of haptoglobin. When we send for urine analysis, there will be hemoglobinuria, because once the capacity of the haptoglobin to bind to the free hemoglobin gets saturated, there will be excretion of the excess hemoglobin into the urine, that is hemoglobinuria. So urine routine to look for hemoglobinuria is again very important when it comes to intravascular hemolysis, whereas such things will be absent in extravascular hemolysis. Finally, such pigment related injuries will lead to renal damage. So again, if renal parameters are abnormal associated with anemia, again we have to think of intravascular hemolysis, and usually this will not be affected in extravascular hemolysis. You got the general points in the beginning, that is increased retic count, some peripheral smear abnormality, bilirubin might be elevated, anemia. So all these things will be commonly seen in both the types. But when it comes to differentiation, splenomegaly, very high elevation of LDH, and mainly haptoglobin as well as hemoglobinuria. These things will help us in differentiating. So once we are clear regarding extravascular or intravascular hemolysis, what to do next? First we will see about the extravascular hemolysis, which is happening mainly in the spleen. We all know that all RBCs will undergo flexibility test in the spleen. So if they are morphologically normal, they will pass this test. But if there are some morphological abnormalities in the RBC, they will not be able to flex that easily, leading to the hemolysis. So overall, the RBC's morphology is helping to pass this flexibility test. So now, if there is any abnormality in the RBC morphology, it will not be passed and it will lead to extravascular hemolysis. So what are the pathologies which will lead to dysmorphic RBCs? So for that, we have to look at RBC from inside out or from the outward to inwards. If you look at the membrane, there might be some reasons such as hereditary spherocytosis, hereditary elliptocytosis, and the newer term which has been mentioned in the recent edition of Harrison, they have mentioned about stomatocytosis, a channelopathy on the surface of RBCs leading to dysmorphic shape of the RBCs. Similarly, if some enzyme defects are there inside RBC, that will also lead to extravascular hemolysis. For example, pyruvate kinase and G6PD. And at the center, if hemoglobin abnormalities are there such as sickle cell anemia and thalassemia, it might also lead to extravascular hemolysis. So among all these, commonest thing which we have to remember is about hereditary spherocytosis and the hemoglobinopathies. Usually there will be family history in these cases and the presentation will be in the early age onset. Mainly such abnormalities are seen in children, but sometimes it might present in the early adulthood as well. And in particular to hereditary spherocytosis, just remember few things like there might be increased MCHC and increased RDW, but there will be normal or decreased MCV. So it will be usually microcytic picture. And we will advise for osmotic fragility test in relation to hereditary spherocytosis. This point is also important. And in treatment, splenectomy will be helpful based on the severity of the hemolytic anemia. And remember, even in case of B12 deficiency or folate deficiency, when we see the macrocytic picture, these larger size of RBCs, even though everything is normal, just because of their larger size, they will be facing some degree of hemolysis. We have to consider these reasons when we get macrocytic picture and hemolytic anemia together in a patient. Then we will discuss about the intravascular causes which will lead to hemolytic anemia. So when it comes to intravascular, so all those factors I hope you remember by now. Markedly increased LDH levels, no splenomegaly, decreased haptoglobin, hemoglobinuria, and there might be associated renal injury. So if these factors are there, we are thinking of intravascular hemolysis. So in that case, the next step should be to send Coombs test, mainly direct Coombs test. If it comes to be positive, we have to follow this pathway. If it comes to be negative, we have to follow the other pathway. First, we will see about the positive thing. So whenever Coombs test is positive in intravascular hemolysis, we have to think of immunological possibilities, like commonly we have to take the history of previous blood transfusions leading to immunogenicity and intravascular hemolysis. In that case also Coombs test might come as positive. So this will be decided based on the history. But if this history is not there, we have to think of some autoantibody mediated immune hemolytic anemia. In that mainly we will discuss about warm type of antibodies and cold type of antibodies. Warm will be IgG antibodies. So just remember, warm in Hindi they will call it as garam. So this G is IgG antibody involved in warm type of autoimmune hemolytic anemia, and cold is the opposite one, that is IgM. This is regarding the antibodies which are acting at different temperatures. But the most important thing is to decide whether this autoimmunity is due to some secondary reasons, like secondary to SLE, or some viral infections such as HIV, even hepatitis B, C and all. So we need to get the serology and we need to look for other features of SLE, or sometimes it might be secondary to the malignancy or some medications, even the commonly used ones such as ceftriaxone, even piperacillin, tazobactam. So all these medications might be leading to immunogenicity causing autoimmune hemolytic anemia, even the pregnancy. So these things we have to keep in mind, and related to these we need to ask the history or we need to get the necessity investigations to rule out secondary autoimmune hemolytic anemia. But if the Coombs test is positive and all these causes are ruled out, we have to consider it as primary idiopathic autoimmune hemolytic anemia. This is about those patients who are having Coombs test positive. But in some individuals, when you have suspected intravascular hemolysis but Coombs test turns out to be negative, in that case, what we have to do is we have to think of some other reasons which are causing lysis of RBCs inside the blood vessels. To list out such reasons, remember March hemoglobinuria or history of prosthetic valves. Some other reasons might be infections. For example, malaria is directly causing lysis of RBCs inside the blood vessel, but there is no autoimmunity. So we have to think of such things also, and we have to look for the other features of infections. And some medications, drugs, which will directly target RBCs and they will lyse them. For example, methyl dopa or some other medications as well. So we need to take the history of any drug correlation leading to recent hemolysis. So all these things should be kept in mind when the Coombs test turns out to be negative in case of intravascular hemolysis. Along with these, we have to remember one more condition, that is paroxysmal nocturnal hemoglobinuria. This will also lead to intravascular hemolysis, but there is no autoimmunity. That's why Coombs test will be negative. So that is about PNH. Some of the key terminologies related to PNH will be CD55, CD59 anchoring will be lost, leading to complement activation, which will attack RBCs inside the vessel itself, leading to hemoglobinuria. Mainly in the early morning sample, the patient might see dark colored urine and there might be chances of abdominal pain, priapism, because the loss of hemoglobin will compromise nitric oxide pathways, leading to vasoconstrictions, causing abdominal pain and priapism and all. Even the same mechanism is the reason for thrombosis. So they might present with cortical vein thrombosis and some other venous thrombosis. So these are all the important things in relation to PNH. This one I have already discussed just now. So whenever there is intravascular pathway but no autoimmunity involved, like Coombs will be negative, in that case we have to think of March hemoglobinuria or prosthetic valves, some medications, infections, even hemolytic uremic syndrome. So these will also lead to microangiopathic hemolytic anemia. This is also an important topic, but as of now we just enlist it as a cause for intravascular hemolysis. When you got to know about all these things, you also have to remember regarding chronic RBC destruction. In some individuals, there might be hemolysis happening over a long period of time, but they might not have been manifested. In that case, sometimes we will even see compensated anemia, leading to almost normal or slightly reduced hemoglobin. And there might not be marked elevation in the bilirubin levels. So even this one might be normal or slightly increased. But there might be other clues of chronic hemolysis. For example, gallstones formation because of the long-standing hemolysis. Or there might be some skeletal changes which are giving clue regarding the bone marrow overactivity because of the compensation for this hemolysis by increasing the production of RBC cell lineages. So this change might be the only clue. And always remember to take family history, especially in case of extravascular hemolytic causes. So I hope you have understood the approach to hemolytic anemias. Just to summarize, remember, whenever you think of anemia plus raised bilirubin, you have to suspect hemolytic anemia. This is the first point. And look for some other features such as take the help of peripheral smear, LDH, palpate for spleen. If the facility is available for haptoglobin, send for it. And even urine routine to look for hemoglobin urea. So if any of these factors are there, then you have to strongly suspect hemolytic anemia and first divide it into intravascular or extravascular. In extravascular, it is mainly in the spleen. So RBC morphology related problems. When it comes to RBC morphology, come from out to inward, like membrane problems, enzyme problem, or hemoglobin problem. But if it is fitting into intravascular, then send for Coombs test. Again, divide it into two things, whether Coombs test is positive or negative. If it is positive, think of autoimmune hemolytic anemias, autoimmune. In that, first look for the secondary causes. If nothing fits into, consider it as primary or idiopathic autoimmune hemolytic anemia. And if the Coombs test turns out to be negative, look for other mechanical causes and always keep in mind regarding PNH, paroxysmal nocturnal hemoglobin urea. Please share it as much as possible so that we will not miss this important and interesting case approach whenever we get cases of hemolytic anemias. See you in another such informative video. Till then, read well. If you have any doubts, put it in the comment section.